Hi everyone, General Manager Tony Mazzucco coming to you with our weekly Facebook Live update. We are a day later than usual this week due to town meeting, and I'm a few minutes late due to some technical issues, so I hope we don't have any problems with the broadcast or the audio or the sound. I am doing this from the office. Windows, as always, likes to remind you to update things when you're trying to reboot your computer, getting ready for a Facebook Live, and then, of course, you can't speed up those updates, so hopefully everything is working. Hey, Catherine, thank you for joining us this week and every week, especially on a Friday, which is not our normal day. We've got a variety of COVID updates, and we're going to talk about the vaccine and then update everyone on town meeting a little bit as well. Hey, Doris, thank you for joining us. Glad to know that the audio and the sound is working, and I did just get my Facebook update that the town of Norwood is live. So welcome, everyone. We are going to go ahead into our COVID numbers, and we're going to talk about that because there's actually some positivity this week, which is a good thing. I know sometimes I can be a glass half empty kind of person, but our total case count for the last 14 days is 284. Which is good. That's actually a decrease of the last couple of weeks. Our average daily rate is around 67. That's that daily rate per 100,000. That's that number that the state has always sort of looked at that has lost some relevance in terms of tracking, but is still down, which is good. And the positivity rate, or the percent positive for the past 2 weeks, is 6.3%. Now, what's particularly good about that 6.3% positivity rate is it's the fourth week in a row it's been below 7%. Now, we do know back in the summer we were hoping, man, I hope it doesn't go over 3. We think we can do with a 2 or 2.5% rate. But we're starting to see a ever so slow, I don't want to say increase in the numbers, but an increase in the positivity of the numbers. So 4 weeks in a row, the positivity rate has been below 7%. We'd love to, again, see that continue to decline where it gets below 6%, below 5%, below 4%. What we're seeing as we head into our first winter with COVID is the type of activity really does make a difference. On the one hand, we saw our peak from the holidays because people are together. Right now, what you're seeing is businesses are slowly reopening, and the governor is changing some of the business practices. Bars and restaurants can be open until 1 a.m. Capacity Monday goes from 25% to 40% for movie theaters, gyms, and stuff like that. But things like snowstorms actually help prevent the spread of COVID because why? We're all staying home for that day, and I think whereas indoor activity generally is more risky than outdoor activity, we think right now there's just a lot less indoor activity going on as well, which is a good thing. Two particularly interesting data points as we look at our COVID numbers. One is the testing rate for the last 2 weeks, 5,100 tests in the last 14 days. That is absolutely incredible for the amount of testing that's going on in Norwood. And we pulled the numbers for Norwood residents testing starting going back to about a year ago, and the number is actually just over 50,000 tests. So Norwood residents have had 50,000 COVID tests. Now, that's folks living in Norwood. That doesn't count how many were physically done in the community. And obviously some people had multiple tests. I had a couple myself. But when you think about it, that is about a test and a half for every resident of Norwood. Many of you know people who have been tested or tested several times. Some of you have probably never been tested. But 50,000 tests. If you had told us 10 months ago, 11 months ago, we'd be at 50,000 tests, we'd say, oh man, things would probably be over by then. But what it shows is that we still have a very heavy, very aggressive testing program, both locally and throughout the state. That's a really, really good positive number to come out of it. So overall, our numbers are looking good everywhere we can go. Testing is up, total cases is down, positivity is down, the percent positive rate is down, and those are all good things. We're particularly happy to see the 5,100 tests over the 2-week period with the, sorry about that, phone's giving us one. The 5,100 tests over the 2-week period with the 6.3% positivity rate, because the fact that we did so many tests and the positivity rate came down is an indication that the data is much more valid and it's good solid data. Early on, I mean, we have the testing of the percent positive rate for cases early on, not particularly as valuable of a data as the 5,100 tests over a 6.3% positivity rate, but we're very happy to see that. So those are where we are with COVID. We're doing good. It is always important to continue to have good practices. Avoid large gatherings. Avoid, reduce your gatherings if you do happen to be out with folks. Continue to wear your mask. We are seeing people start to wear 2 masks in some cases. The more the merrier. It's definitely safer. I think you got to look at your own risk level and look at what you're doing. I wear a mask in the drive-thru most of the time. I probably forget every now and then. Is 2 masks when you go through the drive-thru necessary? You're certainly not hurting anyone. If you have to be in a room with 5 or 6 other people for a couple of hours, if you're comfortable with it, it can't hurt. Continue to wash your hands. continue to practice good practices, and stay home when you're sick if you're able to. Those are the big things in terms of slowing and eventually eliminating the spread. So good work on the COVID numbers. Moving on to the vaccine, there's some positivity there. We're still frustrated at the local level with the overall rollout of the vaccine, and it's sort of a federal problem, and the state at the command center has not relied as much on local public health as we would have preferred. Local public health in Norwood and throughout the country have been practicing for mass vaccinations for 20 years. We've been doing it for 100 years. There's probably an attitude sometimes that, oh, the locals can't do this or that. The locals know the community. There's also no regional entity. I guess if the state was doing it on a county-wide level, that would be one thing. But Wegmans has some vaccine, CVS has some vaccine, and it's sort of like, everyone knows that Oprah meme of you get a car, you get a car, you get a car. That's how we sometimes feel the state and the federal government are doing with the vaccine, just sort of do-do-do-do-do, and different groups are getting it. We could have facilitated the process better locally. It's also interesting, there have been sort of new definitions of first responders and categories sort of invented as a result of COVID, whereas I think 20 years ago the state said, well, these classifications are first responders, these people need to be taken care of first, and that's all sort of getting shifted around. So a little bit confusing there for everyone, and it's confusing for us. Things are changing on a daily basis, and again, if we had more doses here, we would do more folks locally. The Gillette Center is up and running at Foxborough. We do encourage people to go onto the website. They've made some good improvements every day. They're getting a little bit better. It's still a little challenging for some of our seniors and our older seniors in particular to be able to get to Gillette, but it is up and running. The state is releasing, I believe, another 10 or 20,000 appointments there. People are reporting after the first few days it's gotten better and it's gotten a little bit more, the system has been improved a little bit more there. So we always encourage you to continue to look at that website. Our own local clinic, we're still being limited to 100 doses per week with the state. We are tying in with some other private vendors and saying, hey, if we have overflow, can we send you 10? Can we send you 20? And so far we're seeing some success with that, but it's a matter of we don't know who else has vaccine available. It's kind of a strange distribution system. You should register online if you're in the current phase or the current categories. If you are absolutely unable to register online as a senior, because right now it's just senior 75 plus, I do believe you could be in phase 1 and somehow unable to register online. You do have two options, but there's some caveats to both of them. If you live in Norwood and you're a senior and you want to register and you're just unable to work your way through the online registration system, you can call the senior center, and Carrie McCarthy, our senior director, and her staff will take you through that process, and they'll be able to help you with it and get it done. Remembering that our local clinic only has 100 shots a week. So as you go through that process, she will keep a list. When her list gets too heavy, she will have to cap that, but that is just for people who absolutely have no internet access, do not have an internet, can't put it all up on the phone, and can't do it, because that's not likely to be a very fast process. Now, Gillette, or if you wanted to go to Fenway, I suppose, the state's put out a new number. It's 211, so you just dial 211, and that can help you, if you're in those categories, register if you have no ability to register online. The only challenge there is they will register you for Gillette, they will not register you for the local Norwood clinic. So you need to be prepared to go to the stadium in Foxborough to get your shot. If you get put on a wait list there, which some people will, it is a much larger wait list as well. So it's certainly an option. We said last week that it's going to be a long march for the vaccine. We know it's here for some people. It's going to take time. Some people have already gotten it. Some people won't get it for a couple of months. So looking that it's over the course of a couple of months, plan out your options. If you want to wait to be able to get it locally, that will take some time. If you go in the state system, they may register you. It may take time. You may be able to get an appointment. Many people already have. Thousands of people already have at Gillette, and that's a good thing. If you have the opportunity to get an appointment somewhere, we always encourage everyone to go ahead and get it wherever you can. We know that the first responders now are getting into their second phase, or I should say their second dose. Some of them had other jobs at other medical facilities. By all means, be able to do it. There are some school employees who also have a medical role. They're able to get the vaccine. By all means, if you're able to get it somewhere, log in, register, and get it. We've done 280 doses at the local level, so that's what our local public health clinic has done here in Norwood. We've got 70 more scheduled this coming week, and we're scheduling 110 second doses next week. So we're finally getting to that second dose. Those will be for most of our first responders. I want to talk a little bit about what happens when you get the second dose, because there's been a little bit of discussion about people not feeling well. There's sort of two kinds of, and again, anyone who's a medical professional can obviously explain this better than I can, but there's really two reactions that you have, or one or two reactions you have to something like a vaccine. One is an immune reaction, the other is an allergic reaction. An immune reaction is usually a good thing. It means your immune system is actually working, that you're producing the antibodies, that you're sort of getting a little feverish to actually fight whatever it is that you're getting a vaccine for. Most people will get an immune reaction, and not most, but a fair amount. All that means is that's that day that you sort of feel wiped out, you feel a little bit of may feel a little sick. That's a good thing, because that's an immune reaction, and it means that the shot is working and that your body is working as well. Christine, I will give an update on the hospital in just a few minutes, although then it's the same old. They're still waiting on their insurance practices or the insurance policy. So that immune response is a good thing. Some people do have a allergic reaction, but there's allergic reactions, remember, to just about anything. And I always give the example, if 100 million people ate a piece of shrimp today, some people would have an allergic reaction to shrimp. I might be fine, you might be fine, some people have an allergic reaction. Some people, I can eat Reese's peanut butter cups all day long. Some people have a serious peanut allergy, and they would have a problem if they ate peanut butter. So there's always some allergic reaction across a large population. What we've seen is the allergic reactions so far to the Moderna vaccine and any other ones is actually very minimal. There's very few allergic reactions. Again, if you're worried about, well, you heard this story, you heard this person had an allergic reaction, remember, 100 million people today were to eat shrimp or peanut butter, some of them would get very sick from it, because there's always some sort of a natural allergic reaction. The overwhelming majority of reactions are simply an immunoreaction, which is normal. I know some people report feeling stiffness in the arm and the shoulder. The last time I got a flu shot, I certainly got my arm was sore for a day or two. Remember that a shot is still a shot. They're still sort of stabbing you. If there's any nurses, they could confirm this, but I've been told that if the vaccine is a little bit warmer when it gets given, it doesn't hurt as much. You sort of hold it in your hand for a minute or something like that. I don't like needles or blood, so I couldn't say that I verified that. But don't make your local friendly nurse upset. But sometimes your arm is again getting stabbed. You're gonna feel a little pain from that. But by and large, the reactions have not been bad. The media is hyping up here and there that you hear about 1 in 100,000 people have a bad reaction. Again, that sometimes happens with shellfish. It happens with dairy. It happens with peanut butter. There's always going to be some reactions. One question we did get is our clinic for that local public health is running is here at Town Hall. Why not do it at the senior center or another facility? Both what we've been advised by the state and what we've sort of learned is the vaccine being very fragile. Once it's defrosted, it's much more susceptible to breakage or to damage. And it's so fragile, we don't want to take the risk of moving it to the senior center or moving it to the high school. If we were doing sort of a mass vaccination, we would do that. It's a little bit easier. But we're hyper-focused on not losing even a single dose. And we're only getting our 100 vaccines a week. So until we've gotten through a much more wider swath of the population, and until the state can guarantee us that they would replace the doses we might lose. So if we were to drop a dose, and that rarely happens, but if we were to lose 10 or 20, we can't just call the state and say, hey, send us an extra 20 next week. We're sort of been told that our number is 100. So we're being hyper-focused, keeping it as safe as possible, and only moving it the bare minimum, because remember, we'd have to move it there, and then if we had any we didn't use, we'd have to move it back. We will look at either using the senior center, or it could be the high school, it could be the civic, different places, when we get more doses and our clinic expands. That's always sort of been part of the plan, and that's that's something we want to do. We are paying extra attention with police details and with extra care of the parking area near Town Hall where you enter Memorial Hall if you are getting your shot here at Town Hall. So we're trying to make that as easy on people as we can. Pro tip is to move your arm around for the few hours after the vaccine. See, I did not know that, and when I finally get a shot, I will make sure I use that. I should have done that after my flu shot. And great to hear from Dana and Lee that no reaction. Most people won't have a reaction. And again, the overwhelming majority, if you do have a reaction, it's just an immune reaction, which is a good thing. It means your body's working. And some people will have no reaction, and a rare amount of people will have an allergic reaction. One of the challenges we're starting to see, and what we're facing that we need everyone to be good on, those of you who are getting vaccinated, you're going to need to go back for your second dose. You need to pay attention to that second dose. You have to go back for the second dose. You need to bring your card. Consider it your civic duty. It's your role to play in the battle that we as a community and as a country are facing with COVID. I know it's, hey, I got my shot, and then it's, oh yeah, do I want to go back? Do I want to go back? The entire country has invested a lot in this. We need everyone to be hypersensitive to when you go get that second shot. Bring your card, get it on time. Don't just say, oh, I kind of wanted to, nobody's going to the beach in February, but wanted to go to the beach in February on this day and I'd rather do this. Please, please, please pay very, very close attention to that. It's absolutely critical that when you get called to schedule that second dose, please make it a priority. If any of your employers out there and you know your employee has to go get that second shot, you let them go get the second shot. It's absolutely critical that we do that. If you are a Norwood resident and you're a senior and you need help, I said you can call the senior center. That includes if you need help with transportation. We know there's a lot of folks calling on behalf of their elderly parents. We can't can always go out of town, but we can certainly help you here in town. So, as I said, if you are a senior and you need help registering, you can call. If you're in that 75 plus category for now, you can call the senior center and Carrie and her team will help you. We are not sure when we're going to get to teachers, other first responders, critical infrastructure workers, housing authorities. Those are supposed to be coming up. We had thought as part of the state's original plan we'd be doing teachers at the beginning of February. The day we get shipped 500 doses, we can do the school department in a day. We're just anxiously waiting for that. And Doug had posted here, CVS is posting clinics. You'll only get a shot through a reputable place. I consider CVS reputable, Walgreens. I don't know why the state and the federal government are not relying on smaller local pharmacies, which again would have made a huge difference. Wegmans apparently had vaccine available, so you'll only go on through legitimate sites. To be clear, you're not paying for the vaccine, so if you're going through a site and somebody says, okay, you've got your appointment scheduled, it's $19.95 or whatever, that's a scam. Don't do it. It's free, insurance or not, so don't have to pay for the vaccine. So more will come. This is still the early stages of it. Moving will increase absorption. Ice will alleviate discomfort. Thank you, Doris, for those. See, I never thought to ask how to make a shot less uncomfortable, and now I'm learning quite a bit because my shoulder was a little sore, but I think Stacy was angry at me when I got my flu shot this year and just jammed it right in. But that's good to know. So the volume of the fluid is likely to cause the discomfort. The larger the volume, the longer it takes to absorb. I have no idea if it's a lot of fluid in the Moderna shot. Again, I am not a nurse or a phlebotomist or any kind of a medical professional. I always tell people you shouldn't take medical advice from me. I take it from the experts. But I do know when our first doses came in, I looked at the box and I said, "Oh my God, there's only 80 doses there. There were supposed to be 800 for the region." And Stacy just kind of shook her head and said, "No, there's 800 there, Tony. There's 100 in a box." And of course, I was amazed that there was 100 in a box, but I struggle to put Band-Aids on. So that being said, I just want to caution everyone, we're slowly but surely getting there with the vaccine. It's just going to be a long rollout. I haven't gotten my shot yet. Some of the health department staff haven't necessarily gotten their shots yet. We're all just slowly going to get there. At 100 a week locally, it's going to take some time. Gillette is ramping up and the other large centers are ramping up, but it's going to take time. I did read that Moderna's increased the weekly shipments they're giving to the federal government by something over 1 million. There was an article on maybe GBH that it said Massachusetts' Moderna is increasing their shipment, blah, 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 blah. And I wanted to go on there and correct it and say Norwood's Moderna is increasing the shipment. But, we can all share in the credit, I guess, with the rest of the state. So that's it for COVID and vaccine-related updates. I'd continue to be happy to answer any questions everyone has. Appreciate all the people chiming in that have had it and had no pain and were able to get their shot. We're always happy to hear stories about it. Oh, one other item. If you are a veteran, contact the VA. They do have shots available. They do have some conditions they make you go through. They may not have as much at the time. I know somebody mentioned it next week. We got it again. We want everyone to, if you're a veteran, contact the VA. Question for Doug. Sister takes care of her homebound mother. She has a vaccine registration for the homebound. Does Norwood have a similar program? They can go on through, are you talking about if it's the resident who's homebound? They would register just any other way. If it's for the caretakers, the state did make a provision for caretakers. They're considered, I believe, in that phase one or that latter part of phase one, so they could go ahead and register. the same way you would when we release our numbers or when we release our schedules. They could otherwise go to the Gillette site. Doesn't the vaccine go bad? It goes bad if you were to take it out and leave it out for, I believe, 6 to 8 hours, at least the Moderna one. So by doing our clinic here at Town Hall, what we're actually able to do is you take it out, it sort of defrosts for a little bit, and we do that about an hour before we do the clinic, and then you run through the clinic. We know how many people are scheduled, so we know how many doses to take out. When we talk about always putting a dose in an arm, that's when you're sort of grabbing folks and saying, okay, we have one extra dose. Who do we, how do we go? Where do we go with it? But we have appointments in 10 individual blocks or blocks of 10 people, and it's 10 doses per vial that you take out. So you just take out one vial for every 10 people, and it really, if you're doing it correctly, it really minimizes the potential for any loss. You're not able to put it back into the fridge. One of the problems, or the freezer I should say, one of the problems that we were worried about was one benefit to the state rearranging the order of who gets their vaccine is you're supposed to always go up the list if you have extra vaccine, and you never have extra, but I'll explain that in a minute. And then if you can't go extra, then you go down. Well, at first we were saying, well, that's great, but going down is kind of tough because, we started coming up with ideas, different lists of people and everything, and then all of a sudden the vaccine supply was basically, we were told it would be nil. So what we would do in a case where, let's say we had 10 seniors registered, and we get word that one of them isn't able to come in for some reason, they're absolutely not able to do it. Kerry has a list of other seniors on that list. We would just start grabbing people from the next day's appointments, from the rest of the appointments, and build in as much time so that way we're just calling someone else. So we have 100 appointments in a week. We know we could probably do 1,000 in a week. We would grab somebody else off that list of seniors. I know there's concern about there that somebody had sent us a message saying, before you put it in some young, healthy people, we're not putting them in young, healthy people. We don't have enough vaccine to just sort of willy-nilly grab a young, healthy person, if you will, and give them a vaccine. Although some young, healthy people are first responders and critical infrastructure workers, nurses, etc. At 100 doses a week, we're almost never going to have anything extra. Our clinics are so closely managed that at 20 to 40 people a day, we're not going to necessarily have that problem. Once we get up to 500 a day, let's say, if the state increases our allocation, you might have not a problem, it's a good problem to have where we're just doing so many that we always can grab a few extra people and get some done. However, by the time we get there, it means that the vaccine supply is much more widely out there. I'm not sure if they've reached sort of full ramp up in production with vaccine and we're only going to continue to see these numbers for a while. If that's the case, as I said, we'll be at this for a while, and we can look at, certainly April and May as times when there's a lot more vaccinations. Although I do believe nationally we finally have more people vaccinated than have tested positive for COVID. So we're getting there. It's like anything else. It's a day by day, little by little by little, getting there. Phase 3 results for Johnson & Johnson. So what's interesting, the J&J vaccine I think was sort of misreported. There was concern that it was only 65% effective. That was at preventing sort of the moderate to severe cases. It is equally successful as Moderna and Pfizer with the severe cases, which is what you want to do. The Johnson & Johnson one can be refrigerated. It only requires one shot. I think once that comes out, that'll really be great for rural communities. It'll be great for some congregate care settings. It'll be great for dealing with the homeless population, the prison population, where you just need that sort of simplicity of application. I think it'll be great for that, and more vaccine will continue to roll out. I think Moderna is shipping a couple million a week. Their summer production totals were something like 1 million a day, so they've upped their production to around 5 million a week. They're shipping to the federal government. Wish we could divert one of those shipments to Norwood, but something tells me into Massachusetts. Something tells me the federal government wouldn't be too cool with that, but it doesn't mean we wouldn't try. So it's just going to be a long slog with the vaccine. I am happy when we first started these updates, it was all COVID all the time. And now it seems like we have as much information to report on the vaccine as we do on COVID. Not that COVID is any less deadly or less serious than it has been, but our numbers are starting to go in the right direction. And little by little, it's like starting a savings account. You throw a couple dollars in, and eventually there'll be enough money in there. Eventually there'll be enough vaccine, and we'll get it out there. Average sort of healthy, middle-class, working people in an office, by the time they get the vaccine, if you're in that category, I'd expect it to be a little bit later in the year. Next up is, once we enter the next phase, people 65 and plus with comorbidities, housing authorities, more residents living in congregate care set or in housing authorities, I should say, not congregate care, as well as more infrastructure workers. I do anticipate the state breaking up that next block of phase 2 into a couple of different phases because it's still quite a monolithic block. I do hope that teachers and educators are at the beginning of that block, but remains to be seen. Got a question about the hospital. So we again meet with the hospital staff probably every other week. They've actually been helpful. And Stewart has a little clinic in Westwood. We've been talking about being able to send them some overflow. They're still working through their insurance process. They're hoping, the last time we talked to them, they're hoping to have an announcement sometime in April or May is what they told us. I think they're obviously very sensitive to the challenges of going through their insurance process. And, you know, my understanding, or we're seeing it from their perspective, the hospital being a total loss, they probably need their insurance company to come up with $200-300 million. And any of you who've been through an insurance claim process, sometimes that's just not that easy. The number of times our inspectors have had to go in there, both the fire department and the building inspectors, the reports that have to be read, we're in meetings with them all the time because they have their consultants, the insurance company is there, the insurance company has their consultants, and it's working through a very complicated process coming up with the total replacement cost of a building. And then I assume there's probably some discussion in there about, does it totally need to be replaced? You know, what in the way these things work, as an example, is, let's say the hospital has a sprinkler system. So what's the value of a sprinkler system? Well, on paper, maybe it's $500,000. So, well, what does a sprinkler system cost in a new building? Well, it's $900,000. Well, insurance might say, hey, it's only $500,000. That's all we're giving you. And then they're probably going to fight it out with their insurance company the same way you or I would with your auto insurance or your homeowner's insurance, where you say, hey, there was a small fire in my kitchen, and you know the insurance company says, okay, well, here's $30,000 to replace your builder's grade kitchen. You say, well, I can't really get a new kitchen for that, and you know then you fight it out with them. They've committed to continuing to work with us. It's the challenges of dealing with what is a large corporation that's going through a complicated insurance process. If everyone remembers, back in June, we're like, great, the ER will be up and running in August or September, and how wrong we all were about that. I kept saying that, and we kept believing that. As we've said all along, the damage to the building is much more substantial than I think anyone thought. In one of the particular code challenges, and I know I've explained this before, when you do work on a building, and this could be any commercial building, and it exceeds a certain value of the building, a certain percentage of the value of the building, you are required to bring that building up to code. Doris, that's a good question. I'll address the zoning question in just a minute. What you end up having to do is bring an entire building up to code, and almost no building is 100% up to code because the code changes every couple of years. And you know, your home, if you bought it 10 years ago, is largely out of code. But what are the code changes year to year? Sometimes they're very small things. It's your electric wires are 6 inches above the ground in the wall, and then it changes to 6.5. So if you look at the required square footage for a bathroom in a hospital, the code change might have been from 90 square feet to 110 square feet. Well, how do you go into an existing building and then upgrade every bathroom by 20 square feet? It's very hard. Hospitals are actually very good at doing this. Hospitals are great facilities managers in general. So that's sort of the challenge you run into, that it's, okay, the building needs to be completely brought up to code, but making ceilings a different height, making hallways a different width, stuff that comes into the complicated codes for a hospital is really challenging. So I would look at that and say, at what point do you just look at a whole new building? And insurance companies never want to do that. So it's, it's a challenge. Now, Doris, your question, if they don't know what they're doing and what they need, or how do we know the need for zoning, and why should we pass something knowing nothing? So there's a couple of thoughts about that. One is, what we're doing is being proactive. It's a step we can do now rather than wait for it, because they may not have final plans, remembering that engineering and design takes time. So how much longer do you want to delay the opening of the hospital waiting for zoning? And let's say if we wait, because we say we want you to get us a full plan and tell us exactly what you're doing before we go change the zoning, which is never how it really works in development. Are you willing to wait an extra month for the hospital opening? Because, if it's closed 40 months, what's an extra month or two for zoning? I disagree. I want that ER open as soon as humanly possible, and if it means we're doing the zoning now, it's the right thing to do. Hospitals are complicated, and anyone who works in a hospital can tell you this. They're very complicated. But the actual building of a modern hospital, it happens. We know that Norwood Hospital is not going to be, I don't know if there's any 50-story hospitals out there, but it's not going to be 50 stories. It's not going to be 1 story. So you look at the zoning for hospitals in the area, things like Newton Wellesley, the hospital in Weymouth. more or less you know what a hospital building is going to be. It's going to have a central tower, 5 or 6 stories, probably going to have a parking structure, going to have the stuff you need for an ER and an OR. You're going to need some beds in it, and then they're going to maybe want to do something like a North Center or whatnot. So it's actually a fairly standard business model in that sense. So you design your zoning around that. Remember, zoning just talks about what the use is allowed. The current zoning on that parcel has not really been updated in many, many years, and we're pretty certain if you went to rebuild the hospital with exactly the same footprint it has today, you couldn't do it on the zoning that's there. The zoning is designed for general business, it's not designed for a hospital. So what we're doing is creating a medical services overlay district, which is the norm throughout the country for hospital zoning. And yeah, but even then, Doris, what if they're not ready in May? So then we wait till, we wait till November. Town meeting is not easy to call, and it's thousands of dollars every town meeting we have. So if you're waiting to see a full plan and then go to the zoning, that plan might not be ready for a year. And then what if it's even a 30-day delay? I don't think we should delay. We know what the zoning is reasonably to look like. They're not going to be able to build a 50-story building. It's not going to be a 5,000-bed hospital. We know that. It's going to be a fairly standard suburban hospital. It'll have some labs. It'll have some office space. So you build your zoning around that. It's actually a pretty simple process. They're appreciative that we're being proactive, but there's nothing really that they're going to come back with that we wouldn't otherwise do, because zoning is really just allowing you to do what you need to do. They'll be allowed to put a parking garage in there. Find me most modern hospitals have a parking garage. Where you don't see it is some places where they have a lot of space in Florida and Texas where they've built newer facilities and they just have all the land in the world. Now, they're not going to go 20 stories underground, and they're not going to have a 15-story garage. I think the garage in the zoning is limited to 4 or 5 decks. So you reasonably know what it's going to look like. They're not going to do anything out of the box, and I don't know to what extent you'd want something out of the box. So when you look at hospitals, you look at Newton Wellesley, you kind of design it for something like that. You're kind of designing it for something like what's there now, but built as one building with a garage, as opposed to, most hospitals over time just sort of add and add and add and add. So it's a perfunctory step. We had met with them at this point, close to a year ago, and about 6 or 8 months ago, and said, what are you looking at? And they said, this is what hospitals look like when you build them. It'll have a similar number of beds. Again, there's not going to be a 1 or 2 story medical office building, and the MSOD allows a hospital to be built. We want to build a hospital, plain and simple. The Mass Nurses Association has been, we've been in regular contact with them. They are adamant about the hospital being rebuilt and adamant about the zoning passing. I think we have an 80 or a 90-foot limit on the hospital, and they can go a little bit higher with some exemptions for some of their equipment. We've actually heard from both a lot of the nurses in the community and from other communities, they want it to be even higher. They want it to be even bigger. Yeah, I think we're not necessarily opposed to that, but the reality is it's only ever going to be so big. You're not going to have a 20-foot, you whatever. You're not going to have a 20-story building in Norwood, especially not for the hospital. So we've written the zoning. It's pretty common to hospital zoning. I don't think Norwood's going to come up with unique hospital zoning. It's been really hard to see the maps on TV. Are there homes that may be lost? No, there aren't homes that would be lost. Remember, Doris, that if there were homes that were going to go away, the hospital would have to buy those homes and buy the people out of them. And they don't have a right to eminent domain, so they'd go to this person and say, look, we want to buy your house, and you either come to a deal or you don't. The hospital zoning is largely limited to their existing lot. I believe the height limitation is 80 feet. Which by comparison, the Carillon Tower is, I think, 110 feet. And they can go above that for the appurtenances to the building, which are things like their wires and the little stuff above it. So you'll probably see, I'd say, I think it's going to be a 5-story building. And the reason I'm saying 5 stories is anything above that triggers high-rise construction, and the codes completely change for high-rise construction. And it becomes infinitely more expensive to do high-rise construction. But a hospital is different than a house, and it's different than an office building. Hospital floors, Dennis, you and I may not agree on everything, but I agree with you 110%. Build, build, build. More tax revenue, more jobs. We want the biggest, best hospital we can get. We know it's not going to be 50 stories, so build it. I agree 110%. I'm even going to like that comment, because I agree. We want the hospital to come back. We want it to be bigger. Remember, they're a taxpayer. I know some people like to complain that, oh, Stuart, they're a private company. We have issues dealing with private companies, and big corporations are more nebulous than government. But they pay $1 million a year in taxes. I want them to pay $1.5 million. I want them to pay $2 million. That's all great for the town. It's great for you as residents. Norwood Hospital had 1,400 jobs. I don't want 1,400 jobs to come back. I want 1,800 jobs to come back. I want more people buying services. I want more of an impact on the economy. How many stories can it be? As I said, they'd be limited to 5. They wouldn't go over that. But a hospital story is different than a story in your home or my home, different than an office building. They need, not only is the code requirement much bigger, in a hospital room, remember, you have a lot of gear in that hospital room and a lot of equipment there. So it's different than just an office building, where your typical office building, they might say, okay, a story is 10 feet, and then the ceilings are 8 feet, or maybe it's 12 feet and the ceilings are 10 feet. Certainly ground floors of hospitals, much, much higher than that ground floor. The rooms, much higher than a bedroom. A hospital room is not a bedroom. The hallways need to be spaced. When you think about an ER, and we had a good ER, but it was an older building. Think about, EMTs getting in and out of those hallways, getting in and out of those elevators, getting in and out of rooms, and think of just the normal course of you're in a hospital and you're moving stuff around. Hospitals need to be bigger than an ordinary building would be. So if it were an apartment complex for 150 apartments, it would be one size. A hospital, much bigger. And the taller and the wider that a hospital is, the better. But they're still not reasonably going to exceed their lot size. They're not going to take over the MBTA station. It's not going to be anything like you see downtown Boston with, it's going to be a suburban hospital. It'll likely be bigger than it was before with, better amenities, and we want it to come back. Not having an ER is killing us. It's costing us a fortune, and there's more than the cost. It's more dangerous for residents. It's more dangerous for our cops and firefighters who are having to travel all over the world to be able to just deliver a patient. So we want the hospital back. In the zoning, it's one proactive step we can take. We should absolutely do it. And if Stewart does come back in 6 months and says, hey, we actually think we want to build it even bigger than you're allowing, I would be 110% in favor of doing that. Build it, get the tax revenue, get the jobs, and get the best service for our people here in Norwood. It's having a regional impact, and sure, we're concerned about the region, but Doug, their plans call for a parking garage, but I'm concerned about Norwood, and the bigger they build it, the more it'll be here forever, and I want that hospital here the next 60, 70 years for people in this community. So let's get out of the way of the zoning, and I think it'll pass at town meeting Monday night, if we get to it Monday night, and the bigger the hospital wants to build, the better. We know it's not going to be 50 stories or 20 stories even. It's not even going to be 10. So nothing wrong with a nice, big, new, modern hospital. Let's hope after the misery of COVID, the misery of the June 28th flood, and of losing the hospital in the ER for a couple of years, what comes back is something bigger and better than we ever had. And it's just, again, it's more jobs, it's more revenue, it's more safety for our people, it's more comfort for our seniors. I have no qualms about a hospital being as big as they can make it, because it's the best thing in the world for this town, and it's been great for the town, and it will be great for the town. So I know dealing with these big private companies, yeah, Julie, I agree if we get to it Monday. Remote town meeting, which I was going to talk about, but in just a minute, in town meeting in general. So that's where we are in the hospital. I know it's frustrating that there are no more updates, but we do talk to Stewart. They, Bill Plasko made a joke the other day that we were sworn to secrecy after a meeting. They're like, we're concerned about, information getting out. And we said, you're not giving us anything you haven't already told us. You're worrying about insurance. You're committed. You want to come back. And just from an economic or a business standpoint for Stewart themselves, their incentive to make sure they rebuild. Remember that hospitals work on networks. So your ER sort of feeds your hospitals, and then your hospitals tend to feed other hospitals. So when you lose a location, it's not like a fast food restaurant where you say, all right, I'm going to close my Wendy's in this town, and it is what it is. You just lose that market. Your hospital feeds everything else. Moving on to town meeting, good question. Last night was a challenge, and we could avoid the audio checks. Many of us Zoom all day long, and another hour was awful. So I agree 110%. We actually said we're not doing that anymore. It started off as a courtesy for a few people, and then what I think happened is everyone wanted to check their audio, and we're not going to be doing that, I think, anymore. I agree, but people kept popping up and saying, oh, this person's audio was checking, and, let me see if my audio works. We're not doing that anymore. We're going to start the registration process earlier. I mean, most people ended up jumping on a little late, so it took time. We're adding people to do the town meeting member registration. And in addition to that, you'll be able to get on at 5:30. So we're hoping that process goes a little bit smoother this time. I gotta say, overall, I mean, on the back end, this has been an absolute nightmare to have to put together, and an incredible amount of work. All things considered, we got through 10 articles, and it was slow to get started. It actually worked. May not have been that pleasant. May not have loved it. I still prefer town meeting in a room with people, but I think we did pretty good overall. It worked. Some of the things that slowed us up, at the beginning, I think working through sort of registered speakers and dividing questions and how we call people up, that was a little bit challenging. We've never done it before. I think we got through it. we had our normal town meeting challenges of people just like to get up and speak, and that's what town meeting is for. But I think overall it went pretty good. I'd agree it was a challenge, but I think we made it. We passed 10 articles, and we'll probably pass another 10 this coming week. If we can start this coming Monday, if we can start a little bit earlier, and we'll keep at it. As for May, I think it's too early to be seen. There's some benefits to doing it this way. There's some drawbacks to doing it this way. MAPC was helpful. I'm glad we brought them on. And we, by and large, didn't really have any technical issues. It was the slog in getting through, making sure people are registered. And I will tell you, I know MAPC and the IT staff were hypersensitive to that because we got Zoom bombed on one of the trainings. We got Zoom bombed at a budget balancing meeting, which, interestingly enough, I knew something was fishy because there were actually people at the budget balancing meeting. I said, this has to happen. So, kudos to everyone who's a town meeting member and the IT staff and MAPC for making it happen. I think no one really wanted to do it, really realized we probably had to do it, and, it worked. Sarah, you could always not mention that it's 10:10 and we should close town meeting. We can always try to take a few more articles. We can go past 10:30. Although somebody else would often say, and it's correct, that, decisions made after 11 o'clock at night are usually not good ones. Although we did have our kudos to the people who called the question. I always appreciate the people who get in line and call the question. So it was unique. It was interesting. It was a little slow. We got through 10 articles. We took care of our perpetual care fix, a classification compensation study, number of tax relief for disabled veterans, for blind individuals, and for seniors. And we got through 5 CPA projects, which was, I think, good as well. Some good projects to come down. I know, some towns like to go till midnight or 1 a.m., and we can always do it, but we do all need our rest at different points. So overall, I think, it worked. It was good. It, in some ways, wasn't any different than regular town meeting, because remember, if we had been in person, we would have had more speeches, we would have had more presentations, we would have had, Congressman Lynch there, we would have had Representative Rogers there, and Senator Rush there, and we would have gone through all that. So it seems like the first town meeting we have, each time we have town meeting, we tend to lose the first 45 minutes to something, whether it's registering people or anything else. Zoning on Route 1, I don't think that will be quick. It probably won't be quick, but, my experience with NORA, we tend to give an hour and a half, 2 hours for an article, and then somebody's ready to call the question. I think that's what you'll see on the Route 1 zoning. There'll be a presentation of it. People are going to have one side. People are going to have the other side. Questions are going to be asked. Some motions will be asked. We all know what it is. My guess is we'll talk about it for an hour and a half to 2 hours, and then somebody will call the question and we'll vote on it. And to an extent, that's what town meeting is there to do. It's always tough to try to make zoning changes on the floor of town meeting. Usually you want to kind of try to build a consensus there, but it's, it's tough. Just a quick note on the Route 1 rezoning. What we want to do is we really need to try to unlock the development potential on Route 1. As residential values continue to rise, and that's a good thing, but it shifts more the tax burden onto the residential taxpayer. And without A, new growth, and B, more commercial growth, that burden goes up, but the town doesn't generate any more revenue on it. So the tax base is sort of, it's one pie that we take a certain dollar amount from. And as it shifts between residential and commercial, we're taking the same dollar amount, it's just a different amount of people, a different amount from each section. So the more you can unlock that commercial development, and even increase residential development, it's new growth, it all helps ease the tax burden on everyone. We know there's traffic concerns. Traffic will eventually return, as it always it did, and you kind of have traffic no matter what you do, has always been my opinion. Not that it's pleasant. I avoid Route 1 at certain times of the day, at least pre-pandemic. And population going up, more residents is more consumers. It's always one to think about. I agree. Counting votes was quicker. I actually like the way we were able to do it. Now, I don't think we've done any of the poll questions yet. So the way we'll be voting on the zoning articles is with the poll questions. So that'll probably run pretty quickly. But we have a lot of speakers. Speakers are supposed to be limited to 5 minutes, so if we follow that. It would have been helpful to have the presentations before each of the CPAC items. I think it would have decreased the questions and confusions about how CPC works. So, Doris, it's funny, that's a good question, and we've talked about that. I mean, Pat kind of gave an overview. The CPC actually holds hearings. So it's kind of a catch-22 that certain committees go through hearings and they go through public presentations, and you have the opportunity to see this information 5 or 6 times before it comes up at town meeting. And then it's town meeting's time to vote on it. But if we're sort of bringing everything to no vote at town meeting, like it's never been talked about or never been looked at, it's a catch-22 because that takes up time. but the CPC will say, we had hearings on this, we posted notices and everything. The CPC needing a plan, that's not how CPC works in a lot of communities. You're never going to have a capital plan for CPC where you're specifically identifying 5 years worth of projects. I know Jerry wanted that, and it sounds like it makes sense, but that's not really what CPC is, because CPC is always decisional. When you look at the town's capital plan, we could debate whether we buy a fire truck this year or next year, but at the end of the day, we're going to buy a fire truck. You have to do it. We have some decisional items on our capital plan, and some of it you could say is decisional, but at the end of the day, if you need to put a new roof on an elementary school, you're going to put the new roof on the elementary school. We got to try to plan it out, and you plan it out so you can say, okay, we got to fund a roof this year, and okay, next year we got a fire engine coming, so it's $1 million. We got to be able to pay for the engine, so you know what? Let's not do the roof this year. Let's do the engine this year. You're always going to do a majority of those projects. It's the same thing with vehicles. We're always going to have a DPW. We're always going to need ambulances. We're always going to need police cruisers. So the plan is not just saying that you're doing these things so you know that they're there, but you need to do them. Now, spending on plans without that is silly, but sometimes you're going to plan and not do things. So just because you plan things isn't a guarantee that you're going to do it. I would rather spend money on a plan and come to a conclusion that we've studied something and we're not going to do it than just run whole hog into it. You should always assume that if we're planning or doing a feasibility study that something is going to come down the road, but that becomes your roadmap. So for instance, the cemetery master plan for Old Parish, it might identify $200,000 worth of work that we can do over 10 years, and we might say, all right, that kind of makes sense. We want to do that. Now, Old Parish doesn't need a lot of work, but what if it came back that it needed $1 million worth of work? We might say, you know what, I don't think we want to do that. Same thing with Morse House. We're going to do a feasibility study to see what the Morse House needs and what we can do with it. And it'll probably come back with a couple $100,000 worth of work, which is reasonable. What if it came back with that it was $1.5 million to do the Morse House? I don't think we'd spend that kind of money on it. So we studied it, we looked into it. It's not, it's not doing it. So Sarah, there are parameters and guidelines. If you look at the needs assessment and you look at what CPA is supposed to do, that's all there. Some of it's still going to be decisional, and I think the conflict sometimes comes in because it is all truly decisional. Nothing that the CPA spends money on should be anything essential. Think of the Carillon, great project. The town doesn't need to do the Carillon. We didn't need to do the cemetery. We didn't need to do the chapel. We don't need to study Old Parish. We don't need to do anything at the Morse House. These are not critical government functions or needs. Fire trucks are needs. Roofs on elementary schools are needs. Salt is a need. So you tend to people tend to want to get into it a little bit more because we could never do anything with the pools. We could never do anything with Old Parish. Whereas, a fire truck, as I say, we can talk about it, but we're always going to have a fire department. We're always going to put out fires, literally and figuratively. I'd check out that needs assessment. They go through a very, very thorough process with CPA. And again, it's always up to town meeting to decide. If we want to spend $1 million on a historic renovation project and people just don't want to do it, town meeting gets to make that decision, and that's important. So the CPA committee goes through a process. They vet projects. They get vetted internally. They get approval from the different boards and committees that they're looking at. They go through the statutory process. It's sort of in that needs assessment. John Hall, I think, was right when he said, look at our housing needs. Look at our recreation needs. Look at our open space needs. Now, exactly, Bob's right. It is kind of the difference between have-to-haves and nice-to-haves. And most of the CPA stuff is really supposed to be a nice-to-have, and there's nothing wrong with that. Open space is important. We may have a $7 million open space acquisition. CPA may not be appropriate for that. And one of the other things I didn't mention last night, because I try to not talk the entire time, but we may do a study with CPA money and decide that there's another way we want to fund a project that could be a CPA project. It doesn't necessarily have to be. So, and remember, we did the 1% CPA. So some towns do 2, some towns do 3. So we don't have big CPA dollars. We have comparatively relative dollars. We have comparatively small dollars. So sometimes it's great to get that study money with CPA money, and then maybe we say, look, if the town does want to do this, we've looked at it, it's worth doing. Because it is tough to go to the budget every year and put in a $50,000 study to look at the Carillon. So okay, you study it and you say, is the context within CPA? If we were to buy a 20-acre parcel of land, I don't think we'd pay for it with CPA money if it's $5 or $6 million, because that would probably tie up too much of our CPA money. And I use CPA and CPC interchangeably. CPC is the committee, CPA is the act. but that would probably tie up too much money. But the Saint Street lot, that was a couple $100,000. Perfect CPA acquisition. Perfect of what it's for. And we're going to spend more money improving that property and making it better over time. And that's a good thing. Would we have bought the Saint Street lot if it cost $1.5 million? I think so. I think that's worth it. That was a really good parcel to acquire. But we're always going to look at what we want to do. Maybe the Moore House only needs $28,000 worth of work, and we decide that, you know what, just pay for it out of free cash. Take a reserve fund to pay for it because it's nothing. But think of this as getting the projects going, and this is really starting to queue up those CPA projects. Studies, feasibility studies, and engineering and design generally always follows with the project, except when you find out, the Moore House needs $2 million worth of work. We ain't doing it. Sometimes you can move historic homes. What if we did a study to say, can we move the Moore House? And it comes back and it says, sure, for $2.9 million you can move it. Well, we ain't spending that kind of money on it. And yeah, you could look at it as losing money on a study, but that's what you did a study. You did that study specifically to be able to learn these things, to look at them, and to get an idea of what we need to do, and to tell us should we go forward. In terms of the pool assessment, for instance, I know some people didn't like the idea of a pool assessment, but we spent $1 million on a bathhouse because we needed a new bathhouse at Hawes. We didn't design it in a way that could, the bathrooms could open out into the area and be used, but that's fine. But Hawes pool leaks 600,000 gallons a year. So the pool at Father Max is actually in better shape than the pool at Hawes, but the bathhouse at Father Max is in rough shape. So that's why you really want to study these things before we just say, well, we think we want to do this. Because again, we want to be just cautious about spending that taxpayer money. And CPA money is taxpayer money. Occasionally people will sort of infer that it's not taxpayer money. It certainly is. It's a different pot of money that goes to specific sources, but it's a very specific pot of taxpayer money. So studying and look at these things is taking a step back and trying to be strategic. So that sort of plan you want, you always got to study things before you have that plan. And we might get a study of the pools that says, okay, we need to spend $5 million in 10 years. Well, what gets into the capital plan? What's a CPA project? And what do we want to do with that CPA money? And it all helps make those decisions. So that's sort of where we are with CPA. I think somebody made a comment. Doris said, is it clear CPA cannot be the proponent? So how can they plan when no one has proposed yet? Right. CPA is sort of the vetting process. They manage the process. They manage the projects. They don't come up with their own projects. It's not a committee that's in charge of community preservation projects in development or CPC projects. They're our community committee that vets the projects and decides, are they tied to the money, and are they a good project to go forward, and do they meet with that parameters. So CPA is a very fascinating committee to be on. I don't know if they have any openings right now, but it's great to be on. They post all their meetings. They have hearings, all their stuff. Follow the process. There's always sort of things in the queue with CPA, and a lot of them are interesting projects. And remember, we're just a couple of years in, so it's going to take us a couple of years to get some projects done, and then that sort of starts building where do we want to go and where we want to go from there. And remembering that a lot of the CPA projects are designed to be smaller one-off projects. Adopting it at that 1% rate is not really going to be enough to always do really big projects with it. So you do your $20,000 court restoration here, etc. I do agree, Sarah. We did do it a little weird. I mean, Patrick gave sort of an overview. Maybe what we should just do with CPA projects is give them more presentation time. We're trying to rearrange how we do town meetings so that way, capital will be in the fall. And the idea might be that capital and land use are in the fall. So that way the regular annual town meeting in the spring could be for the regular budget, which takes us usually at least a night and a half to get through. And maybe we put CPA in the spring at the annual because we can take those projects up individually. And again, they are sort of decisional projects and give it the time that it deserves. Because I generally, other towns spend more time presenting the CPA projects, but it's the first year we've had some of these type of projects. So we can certainly look at making a change there. And I'd be happy to hear if anyone thinks that we should do them in the fall with the capital plan because they sort of tie in, but they're not supposed to necessarily tie in. Or if we do it at the spring with the annual meeting. Because remember, this is what we would have otherwise been voting on last May. That got kicked twice. So, and that's part of the complexity. Yes, Patrick in the planning department is leaving us to take the top job in Walpole, so we are certainly sad to see him go. He's been a great asset to the town, and we're happy that he's getting a promotion and a raise, and hopefully he'll enjoy his time over there, and who knows, maybe we can steal him back one day. Better pace and often the capital items get rushed through. Yeah, that's exactly why we want to do capital in the fall like we did. Part of it's that we ended up pushing it anyway, and there's no way we could spend $15 million in November and then need to do it again in May. But we're always sort of rushing it, and sometimes people in their mind can't separate the capital budget from the operating budget, and we just, they are sort of separate things, and we're moving some things that are capital budgeted in the operating budget to be as sort of part of the capital budget, so people can know, okay, this is kind of how it does it, just so that way we can give capital the time that it deserves, because it always comes at the end of the warrant. We've gone through the budget, we've gone through land use, we've gone through all this other stuff, and it's, all right, now let's spend $8 million, and it's like, oh, forget about it. And we want to give it the time it deserves to go through some of the projects that we're actually doing and actually proposing. So spreading town meeting out a little bit more over the year and doing capital in the fall, maybe doing capital and land use in the fall, and the annual and CPA in the spring should just give us time to do things correctly instead of throw everything into May and then pick up the pieces throughout the year. So I think that's a much better model. I think capital outlay is, if not formally, has informally kind of come to that consensus that spreading it out that way will let us do the appropriate amount of time. Because as you know, Sarah and Doris and anyone else on town meeting, Bob, that you get to capital outlay and it's like, all right, I'm fine giving a 45-minute capital outlay presentation and then spending 45 minutes or an hour answering questions on all of these projects and showing pictures and showing videos and showing quotes and everything. But people then get annoyed. They're like, oh my God, we got to go through this again. So we think that pace would be a little bit better. And I might even want to look at whether we try to do town meeting 3 times a year, formally, spring, winter, and summer, and just not have it be such a slog each time, where by the end of it, we're all sort of done with town meeting and something has to get rushed through at the end. But that's my town meeting update. Stay tuned Monday. The best place to watch town meeting is on NCM. As always, we are here to help. If you have any questions, we can get to them in the comments, or you can email us at managers@norwoodma.gov. I want to thank Chris Welch in my office for producing this, and thank all of you who are town meeting members for being at town meeting and for being patient. I want to thank all of you for joining us this week as we do every week. We will see you next week on our regular scheduled time at Thursday. It's always when I want to question the quorum. Never question the quorum. That shouldn't be allowed, but it's always part of the fun of town meeting. So thank you all for joining, and I hope you all have a wonderful weekend, and please stay safe out there. Take care, everyone.